to thank Dr. Swarup and Dr. Steve for providing that background and backdrop, so that's going to make my job easy. And we heard in the last 1.5 days ministers and heads of various departments, program managers, and policymakers speaking about the progress that they have made in the area of HIV and reproductive health, family planning. Now, I'm going to spend next 10 minutes talking about how women living with HIV experience have been so far. It's very critical, to listen to and hear the versions of women linked with HIV and the marginalized women. When I say women linked with HIV, we are not a homogeneous group. We are sex workers who are living with HIV. We are women who use drugs. And we are spouses of men who have been married. In many of, in this part of the region, about 30-35% of the men who have sex with men. You saw Steve's presentation on the AIDS Commission in the Asia Pacific, the slide. 50 million women are at risk. So we are not a homogeneous group of women. So my slide is going to be talking about how we know once we are infected and we are diagnosed with HIV positive. When I say we, I'm also a woman living with HIV for the last 14 years. So the opportunities that we have and the entry points we have are very limited. So how most, I would say, I keep saying in many platforms, it's very unfortunate that the empowerment of women who've been speaking and women living with HIV have come after the infection, not before the infection, because there are no programs to address our prevention needs, as Steve pointed out. So it's very important when I say 4 for women, 4 pillars of the prevention of parent to child transmission. The pillar 1 talks about the prevention needs of women, young women who are in the age of reproductive age groups, when they visit health facilities, what kind of interventions are put in place. If there are no programs, they move on to the next pillar, which is if they are infected in the first trimester or the second trimester or third trimester in their pregnancy, they need to be counseled, which is the pillar 2. They need to be counseled whether they want to continue with their pregnancy or they want to terminate their pregnancy based on their situation, their context, where they come from. Because for many of us, the diagnosis, most women diagnosed when they are pregnant in many contexts and including Africa. So it's a shock for us when we are pregnant and we have come here to this health center, to actually take some services to see how our pregnancy, we are going to have a safe delivery, safe pregnancy period so that we enjoy our pregnancy. But HIV diagnosis brings in shock and it exposes to a whole range of issues, including the violence that we face as a result of the diagnosis. So the counseling should be very comprehensive. That leads to, at the third, women decide to continue their pregnancy, which then we move into the pillar 3, where we need to be counseled and provided information with how we are going to make sure and ensure that the pregnancy is safe and deliver a safe child and who is going to be born negative. So which includes how we can take prophylaxis, what kind of options are available to prevent the transmission from mother to child. And for our own health, what kind of treatment are available. You can, from many of our women have shared the experience of if they are pregnant, if they are diagnosed HIV positive, if women are asked to go for treatment, it's a whole lot of information. It's fully loaded with information. You can imagine it's very complex. And the dealing with the disclosure issues. And on top of that, putting women on treatment, which is a lifelong, if it is for her own health, to manage her own HIV status, if her CD4 counts are less than 350, then she needs to be properly advised. So this information is so comprehensive, need to be very comprehensive, need to be supported. Then pregnancy, then about the breastfeeding practices. So need to be counseled on breastfeeding practices according to the evidence-based. And WHO has come out with a strong recommendation that women living with HIV can also breastfeed their children exclusively for 6 months. So then they move on to the fourth pillar, where the program looks at a comprehensive mother, the child, and the family's care and support needs. They need to be properly linked to other schemes and other sectors. So this is a global scenario. You can see globally 15.7 million women above the age of 15 were living with HIV. And you see the number of deaths that has occurred and the world has witnessed in 2009. I also want to bring your attention to the focus on 22 countries. 8 out of PPD countries, partners in this event and the part of the PPD, are part of these 22 countries. And 7 countries are from sub-Saharan Africa. And this side of the slide, focusing on the India picture. And I just want to highlight on, we have in India about 175,000 sites that provide antenatal care, but only out of that, only 4% provide PPTC, HIV testing facilities. And only that figure is not there, so I'm just having it in my head and I'm talking about. Only 3% provide PPTC and ART and they link. Only 897 centers have antiretroviral drugs. So imagine the situation and the realities and the challenge in front of us in scaling up our intervention. So this is how we lose women. And we talk about the percentages of reaching women and women who have unmet needs and women, what percentage of coverage at country level. You can see this is just a picture and this is from India experience, PPTC coverage. We have 27 million pregnancies every year annually. That's an approximate figure. And 43,000 estimated HIV positive pregnants who are, positive, and which is 0.48% of the 27 million. And you can see how missing. Only 16,954 actually identified through this, systems in place, and we still miss out 60%. Out of that, 11,962 received the nevirapine to prevent prophylaxis, to prevent the vertical transmission of HIV. And again, we are missing 72% out of the 43,000. When you come down to that, the estimated number of HIV also keeping women alive. So these are some of the key findings from the India study, and it's self-explanatory, I don't need to go through. And we have found out these are some of the glaring gaps from this study. Women who test negative are not being counseled further. What if the woman who comes in first trimester and she is counseled and she is negative, but then post-test counseling is not offered. Okay, they just distribute the results. Hey, you take, you're negative, you can go home. But then what if she comes in the second term or third term during the delivery, there is no way they can detect the HIV. So most women are falling through that. So I just want to give one example of how our systems, there are loopholes and they're not really checking and monitoring. So, and then the practices we see different practices among healthcare providers. Private healthcare providers are recommending for top feeding, and public sector are recommending for breastfeeding. So there are no exchange of information and evidences. So we see this clear divide and differences in terms of how the guidelines are being practiced on the ground. And single-dose nevirapine is still the regimen which I think WHO has strongly recommended to phase out. But because countries have stopped the nevirapine and still they are using, it's part of the option A. And now UNICEF and WHO are strongly recommending for option B and option B+. So these are the demands based on our experience. We need to isolate. HIV does not occur in isolation. We need to be talking HIV in the context of SRH. And we need to put women at the center. And the systems need to really address their real needs. Peer support is very important, and it's been proven, and there is a strong evidence. We need to move beyond condoms. And the guidelines for important notification so that male involvement also taken into account. And as I said, we need to really look at what are the current treatment options for women and children and family. So we strongly recommend the humans as critical enablers. We must engage community. You can see the Uganda experience where 50 communities over 9 districts were informed of their rights, given baseline information on health services, and they were issued with report cards to identify their own solution and the plan, their strategies, and implement and monitor their own programs. So we have a number of examples, community-driven examples, and mentor mothers, mother to mother, a lot of experience,